Hi, and very warm welcome back again for this important chapter that is the occupational health. Beta, for your exams, this is a 3 by 5 star MCQ topic. A lot of questions come from occupational health. It is always said that a safety and accomplishment does not happen just by accidents, it has to be earned. As the country progresses, new industrialization open, new markets are there, new factories, new industries. It is important that we should talk also about the occupational health because that forms as the center parameter of further development of the country. So to understand occupational health, we are going to talk about some of the competencies as per your CBME based curriculum. The competencies would be like various occupational understanding of the various occupational diseases or the related injuries along with the specific occupational health hazards. We also will talk about a little bit about the ergonomics principles and what are the occupational health problems that we have in doctors or in health professionals or in nurses or healthcare people. So there'll be a lot of topics that I will be cruising through in this chapter. So I've gathered together around 10 topics that we will be cruising through. Let us start with the first topic, that is the thermal injuries. Thermal injuries could broadly be classified into three types. You can have thermal injuries could broadly be classified into three types. You can have something called as the problem of the heat regulation. Heat regulation. If the heat regulation mechanism is stopped, what is it going to lead to? This will lead to no sweating. If there is no sweating, now the body is going to not maintain the temperature and there could be chances of something called as heat stroke. Heat stroke is what? It is a failure of the thermal regulation or the heat regulation mechanism. Please note there is no sweating. And in a heat stroke, the skin would be very hot and dry. There is no sweating. That is the reason, because sweating actually would balance your temperature. So that is what is a heat stroke. A milder form of heat stroke, again a problem with the heat regulation, a milder form of heat stroke could be your heat pyrexia. In the heat stroke, the body temperature could be as high as 110 degree Fahrenheit. Whereas in a heat pyrexia, it's roughly around 105 to 106 degree Fahrenheit, which is relatively very high. So talking about the thermal injuries, the thermal injuries could be due to three mechanisms. The first mechanism, it could be that is there is a failure of heat regulation. If there is a failure of heat regulation, because the body, how does it regulate the heat? That is by sweating. So the failure of heat regulation, indirectly it means that there is no sweating. There is no sweating. So what will it lead to? It will lead to something called as the heat stroke. What are the features of a heat stroke? Please note there is no sweating, common sense, plus the skin will be very hot and dry. Usually the temperature is roughly around 108 to 110 degree Fahrenheit. That is a super high temperature. The skin will be very hot and dry. There is no sweating. This is what is called as a heat stroke. A milder form of heat stroke, that is called as a heat pyrexia. In heat pyrexia, again, there is a failure of the thermal regulation or the heat regulation, but it is kind of a lower body temperature, that is 104 to 106 degree Fahrenheit. That is for heat pyrexia. A severe form is called as heat stroke. A milder form is called as a heat pyrexia. Next is another type of thermal injury. So that was the first type, that is heat regulation. Another type could be salt and water imbalance. The salt and water imbalance could be again of two types. You can have heat exhaustion, or we can have the heat cramps. Beta, in the heat exhaustion, primarily what will be more? What will be gone? In the heat exhaustion, it is mainly there is water loss. So now because there is water loss, this leads to dehydration. Which is what is heat exhaustion. In heat cramps, it is the kind of opposite, that there is more salt loss. Why do you think there is more salt loss? Because there is more sweating. Because there is more sweating, there is more salt loss. This will cause electrolyte imbalance and this causes the cramps. And this is again a type of salt and water imbalance. That means that whenever the heat is there, you need the salt and you need the water. It's not that you need only water or you need only salt. You need both. That is salt and water. The third type of thermal injury which can happen is because of the altered or impaired vascular pressure. Please note that in certain situations, there could be something called as heat syncope. What do you mean by the heat syncope? In heat syncope, there is vasodilation of the blood vessels, and because there is vasodilation, there will be pooling of the blood in the lower extremities. If there is pooling of blood in the lower extremities, what will happen? There will be reduced cardiac filling, and the reduced cardiac filling, nothing very brainer, and the reduced cardiac filling will cause a slight temporary loss of the consciousness. That is what is a heat syncope. There could be related tachycardia and hypotension. There could be related tachycardia and hypotension. This is what is a heat syncope. So broadly speaking, the thermal injuries could be heat stroke or heat pyrexia, which are because of the failure of the heat regulation. We can also have heat exhaustion or cramps, which is because of the salt and water problems, and we can have heat syncope, which is because of the low cardiac filling. The treatment for all of these, in fact, first is important talking about the heat stroke and the heat pyrexia, is rapid cooling. So what is the treatment? It is rapid cooling. Heat exhaustion and cramps it's not required to rapidly cool the person. The more important point would be to give them more salt and water. That is a rehydration. So solute based rehydration is very important, and heat syncope, nothing very special. It is usually a very temporary loss of consciousness, and you just take the person to a cooler place, let them lie down, they will be back normal. This is what is heat syncope. Coming over to the cold injuries, the cold injuries could broadly be classified into two types. You can have the trench foot or we can have the frostbite. Very simple to understand. Trench foot, foot. So trench foot is during war times. It was found out that people like German and the Nazis and the Russians, they used to stand in trenches for a long time, and the snow used to be there, the water used to be there. They used to stand there, so they got some problem in the foot. That's why the disease is called as trench foot. It is because of immersion of feet or single foot also, immersion of feet in very cold water or ice or snow. So if for a longer period of time, it causes immediate spasm of vessels, vasospasm, and this causes like problem. There is more edema, which causes extravasation of the fluid. There is swelling of feet. So that is what is trench foot. The only way to do is to keep the feet warm, and of course to prevent the trench foot, you need to prevent immersing the feet in cold water. So the only MCQ you would like to remember is immersion of feet in water is what is trench feet. What is frostbite? Frostbite is simple English word. It means a frosting of the fingers or any part. So in this there is crystallization of body fluid, usually in extremities. So if there is immense cold and the finger or something is there in the snow, the fingers or the tissues will technically freeze because body is like more water, right? So if the tissues and the fingers will freeze, they will cause a snapping of the blood supply, and there will be gangrene formation. The only treatment for frostbite or even for trench foot is prevention. But for frostbite, if it happens on the fingers, it is very important to stop the progression towards a gangrene. So the only thing that we can do is rewarming of the body part, rewarming of the body part at the rate of 42 degrees Celsius for 20 to 30 minutes. The technical answer is rewarming of the body part at 20 to 30 minutes at 42 degrees Celsius. Next type of occupational disease that we can take up is pneumoconiosis. Beta, pneumoconiosis, these are usually these are restrictive type of lung diseases. These are restrictive type of lung diseases. In pneumoconiosis, these are essentially, they have to be occupational related, and that's the reason they are called as pneumoconiosis. Different types of pneumoconiosis you already must be knowing. There could be silicosis, asbestosis, siderosis, anthracosis, aluminosis, lithosis, bicinosis, bagasosis, farmer's lung, and so on. So many pneumoconiosis are there. A few important which you would like to remember for your exam is, you should remember what is silicosis, asbestosis. What do you mean by anthracosis, bicinosis, bagasosis, and farmer's lung? Silicosis is because of silica dust, asbestosis due to asbestos. Anthracosis is because of coal dust. Anthracosis is because of coal dust. Then you also should know lithosis, that is because of stone. Bicinosis because of cotton fiber. Bagasosis because of bagasse. And farmer's lung is due to a moldy hay. Slightly in detail, let us have a word about silicosis and asbestosis now. If you talk about silicosis and asbestosis, let us say that this is the lungs. So the first point for you to understand is that why people get silicosis. Why would a person get silicosis? Silicosis is seen in which industries? It is seen predominantly in granite industry, sandstone industry, pottery, ceramic. You can just remember stone crushing industry. It is because of silica dust. Okay, that is the main understanding. So it is because I have understood this in this manner only, that silicosis is because of a dust. If you talk about asbestosis on the other hand, asbestosis, have you ever seen asbestos? Like when we go to buy asbestos sheet, you must have bought it sometime on the car sheds, and usually the sunroofs would be asbestos fiber. So when we go to buy them asbestos sheet, the person will ask you that how many thick you want. So how do they make asbestos? By beating the glass fiber. There's a fiber which is, you beat that glass fiber and you make sheets. And then 1 sheet, 2 sheet, 3 sheet, and you put all the sheets together. So asbestos is technically due to, you can remember it, that it is technically due to a fiber. That is what is going to make the world of difference, that one is a dust and another is a fiber. Now understand how the things work. In silicosis, it is because of a silica dust. Dust will go and settle in the upper part of the lung, in the middle of the lung, or in the base of the lung. What do you want to say? Dust is going to fly with the air. It is more going to affect the upper zones of the lung. It will affect the upper part of the lung. Asbestosis is because of the fiber. It is going to affect which part of the lung? The fiber has to settle down. It is going to affect more the lower part of the lung. First MCQ. Second point. If you talk about silicosis, if this is the alveoli, these are the alveoli. In silicosis, the silica dust, will it be able to enter into alveoli? Answer is yes, it will enter into alveoli. This will cause what? It will cause alveolitis. In asbestosis, the asbestos is not going to enter into the alveoli. Why? Because it's a fiber. So where will it go and stick? It will stick around the last part of the bronchioles, very small bronchioles. So technically speaking, it is going to cause what? This will cause bronchiolitis. So please note, asbestosis is in the lower part of the lung. It will cause predominantly bronchiolitis. Silicosis is in the upper part of the lung and will cause alveolitis. Now, because it causes alveolitis, the third thing for you to know is that if you take an X-ray picture of this lung, you will see some of the nodular fibrosis. Why? Because all the alveoli will be clumped together. So it causes a nodular type of fibrosis. Nodular fibrosis in the lung, whereas in asbestosis there would be a hazy type of picture, that is the ground glass appearance, and this is a diffuse fibrosis. On the silicosis, because it is a nodular fibrosis, it will cause a special appearance on the lung that is called as a snowstorm appearance. It is going to call as a snowstorm appearance. Last point is that which of the following will be having more chances of malignancy or cancer? What do you want to say? Please note that if this is the alveoli, the silica dust is going to enter into alveoli, and technically it is going to cause problem in the respiratory exchange in the membrane part. So the gas exchange is going to be hampered more in silicosis. Whereas in asbestosis, now if you talk about asbestosis, the asbestos fiber is going to go and stick around the bronchiole, last part of the bronchiole. So technically speaking, this will cause mechanical irritation of the bronchiole, and therefore we say that asbestosis is more pre-malignant. It is more pre-malignant. On the other hand, if you talk about silicosis, it is not as pre-malignant. In fact, it is rare to see cancers in silicosis. It is not pre-malignant condition. I will not say absolutely it is not pre-malignant. It is just, we don't say that it is pre-malignant because the chance of cancer would be equal in both the cases. But of course, silica or silicosis has a very high potential to develop tuberculosis. Tuberculosis. It has a very high potential to develop tuberculosis. There are a lot of cases which are silicotuberculoids. So you have silicotuberculosis, and on the asbestosis hand, it is pre-malignant. It can cause which cancer? Don't answer mesothelioma. Why? Mesothelioma is a pleural cancer. Pleura, cancer of the pleura. So this causes maximum amount of bronchial cancers because you understood it causes problem in the bronchioles. So there is a more chance of bronchial cancers. Of course, if you answer mesothelioma, I cannot say it is wrong. Mesotheliomas, they have the strongest association. They have the strongest association with asbestosis. Please note that mesotheliomas, they are a very rare cancer. They are a rare cancer. You see mesothelioma, think of asbestosis, but if a person has asbestosis, think of bronchial cancers. So this is what is some of the basic differences between silicosis and asbestosis. Please note silicosis is with TB, whereas the asbestosis, that is with bronchial cancers. So this is what is the complication, and these are a lot of MCQs which are being asked about silicosis and asbestosis. Moving next to other types of pneumoconiosis, point number 3. What do you mean by byssinosis? Byssinosis is due to cotton fiber dust. It is also predominantly in lower zones of the lung. Why? Because the air is going to settle down. It is with the cotton fiber dust. Point number 4 is what is bagasosis? Please note that bagasosis, in this table also, I think we all have seen that bagasosis is due to sugarcane dust, but the answer unfortunately is not correct. It is not due to sugarcane dust. What is bagasosis? It is due to bagasse. Bagasse is what? That is a sugarcane dust. What makes you think that why on earth would somebody inhale a sugarcane dust? It is a heavy thing. How can it go into the nose first level, and then you believe that it will go even through the nose into your little alveoli, into your little lung also? Why would somebody put that bagasse all the way downstairs? It doesn't happen that way. What industry are we talking of in bagasosis? Can you see cane sugar industries? And most importantly, it is the paper and the cardboard industry. It is the remnant of the sugarcane that is called as bagasse. The remnant of sugarcane is called as bagasse, and there is a fungus which grows on bagasse. Fungus is called as Thermoactinomyces sakari. The fungus is called as Thermoictinomyces cercari. So technically speaking, we can say that Bagasosis is a fungal disease rather than an organic pneumoconiosis. So Bagasosis is because of a fungus which grows on the bagasse, and there is fungus everywhere, and people who are working with bagasse, they may be at potential risk to have this fungal disease. That is because of the fungus. What is the name of the fungus? Please note it is Thermoictinomyces cercari, which is predominantly on the bagasse. So bagasse is going to have this fungus, and bagasse is used in the paper industry. Everything that the copies and all the books that you write on is bagasse. So that is what is Bagasosis, and because it's a fungal disease, that's the reason there is also mottled appearance of the lung. Mottling of lung tissue is there, of lung parenchyma is there. There is mottling of lung in Bagasosis. On the similar principle, we also have something called as the point number 5, that is the farmer's lung. Farmer's lung. Please note that farmer's lung is because of, you saw it in the table, it is because of a grain dust, that is the moldy hay. So the farmer's lung is because of a moldy hay. What is hay? It is the dried form of the plants that are left out, usually after the wheat or the rice. So you have a moldy. What is a moldy? Moldy means a fungal. So what is the name of the fungus? It is Micropolyspora feni. It is Micropolyspora feni. So please remember, farmer's lung is again an organic disease. Bagasosis is also organic disease. Silicosis is usually due to inorganic dust. That is what differentiates between organic lung diseases and inorganic occupational lung diseases. So these were a couple of questions which come on pneumoconiosis. Next is this point number 4 about the occupational cancers. Please note that this is a fascinating topic because a lot of MCQs come from this topic about the occupational cancers. So talking about which is the most common, you can have different cancers, right? We can talk about the skin cancer, lung cancer, bladder cancer, leukemias associated with any occupational disease, occupations which are there. So first MCQ is, which is the most common occupational cancer? The most common occupational cancer that we have is, beta, please say with me, it has been asked 5,000 times, it has been asked in your exam. So please note that the most common cancer is always the skin cancer. The most common cancer is the skin cancer. It is the most common occupational related cancer found in almost every industry. Why? Because people are working with chemicals. So chemicals may cause skin cancer. Skin cancer is the most common cancer. Most common type of skin cancer is the squamous cell cancer. Squamous cell cancer is the most common type of skin cancer. Coming over to the lung cancers, yes, lung cancer is there in many industries. Specifically talking about is the tobacco industry, nickel industry, chromium industry. Lung cancers are pretty important in the heavy metals. In the heavy metal industries, specifically talking about tobacco, chromium, cobalt, and nickel, it is important. And arsenic, of course, these are the lung cancers. Usually lung cancers is again the squamous type of lung cancer. Squamous cell cancer is more with these industries. Also, I would like to tell you that because it is an industrial problem, it is because it's an occupational hazard. Lung cancers are very common in people who are smokers also. So it does have a very positive additive effect. If a person is smoker and he's a smoker only, no occupational hazard, there is some chance of cancer. Now, if this person is a smoker and occupational hazard also, now there is an exponential increase in the chance or in the risk of having cancers. So cancers is like an exaggerated response because of smoking and presence of any heavy metals. Next is bladder industry. Bladders has been asked so many times. You see bladder mark aromatic amines and the benzenes. So two things you need to remember: benzene and aromatic amines are very commonly associated with bladder cancer, very frequently in the textile industries. So people working with the dyeing and the coloring of the clothes or the cloth, that is what is textile industries, bladder cancer. Leukemias has also been associated with benzene and of course with radiations. Leukemia is there, and in fact it is one important risk factor for the healthcare professionals as well. Healthcare professionals also may get predisposed to leukemias because of presence of the ionizing radiations in the hospitals, of course. So talking about what agents, what answer you're going to mark, whenever you see benzene, you will mark leukemias and you can mark bladder cancer. So please note, benzene, whenever you see, you mark leukemia. If you get the single best answer, it is leukemia, that is benzene. Any heavy metals, I have remembered it this way, any heavy metals, if they are asked in your exam, I will mark lung cancer. If they ask me asbestosis, right now, just now we talked about asbestosis, mesothelioma, but the most common cancer, please note, most common cancer in asbestosis is bronchial lung cancers. Bronchial lung cancer are the most common cancer in asbestosis. Any heavy metals, please note it is lung. Benzidines, aromatic chemicals or textile industry, it is bladder cancer always. Whenever the question, they have asked this favorite question a lot of times, dye industry, what is the cancer? Answer is bladder cancer. Then you have the PAH, which is again associated with scrotal cancer, lung cancer, skin cancer. Vinyl chloride is with liver. That is, again, I think it was asked in one of the central exams about vinyl chloride and the liver cancer. And wood industries, I think everybody knows about the nasopharyngeal cancers with wood industry, nickel and chromium, that is the nasal sinuses. So this has been asked a lot of times in your exam previously, so you should be remembering this. Occupational cancer is important 3 by 5-star MCQ topic for your exam. Next is this point number 5. What is Kaplan syndrome? Please note that Kaplan syndrome is seen in construction workers or people who are doing mining. So one is that same problem of asbestosis, silicosis, all those things. So in those cases, in people who are doing construction workers, if they develop pneumoconiosis, plus there is a pathology associated with pneumoconiosis, they may even develop rheumatoid arthritis. Plus there is formation of there could be plus or minus formation of the intrapulmonary nodules, or the fibrosis may happen. This together is what is called as Kaplan syndrome. Where do you see it? It is seen more in construction industry or the mining industry. Point number 6 is again more seen in the labor workers or in the construction industry. Construction workers. It is more seen in people who are doing heavy job, who are working with the drill machine, who are breaking the earth. You might have seen somewhere that people who are like just destroying that road. You need to open the road for something, so they'll do that tuck. So that actually will cause a lot of problem in the hands. So that is called as a white finger syndrome. White finger syndrome. It is seen as a vibration injury. It is seen as a vibration injury. It is because of vasospasm. It is because of vasospasm in the fingers, in the hands and fingers, which cause loss of sensation and pallor and color change in the hands. That is what is a white finger syndrome. It technically is related with the Raynaud's phenomena. That is what is the white finger syndrome. Next is we come to your favorite disease. A lot of times it has attracted again a lot of MCQs from plumbism. Important from your MCQ exam. Please note 3 by 5-star MCQ topic. What is plumbism? Plumbism is lead toxicity. Plumbism is lead toxicity. It is also known as the painter's colic. It is also known as the painter's colic. It is more found in painter occupation and it is associated with colic. See, what happens is that plumbism will happen due to lead. What is the most common root of plumbism? Like, why would the lead toxicity happen in a person? Please note that the most common root for plumbism is not ingesting lead. It is inhalation of the lead. Most common route in case of children is not inhalation, it is ingestion of lead. ingestion of lead or some toys which have a lot of lead, that is the most common route in children. But in adults, if they ask you if nothing is given, beta, don't think about children, think about a normal industrial worker. That is, inhalation is the most common route of plumbism. Next is, what is the most common industries which are involved? The most common industries in today's world, it is battery industry, automobile industry. Then you also have, very importantly, we have the paint industry. If you get single best answer, which is the most common industry for plumbism, answer has to be battery industry. Otherwise, we can also have the automobile, the paint industry, so which are also people who are like working as plumbers. And that's why the name is plumbism. And that's why the plumber is called as a plumber, because they had a lot of plumbisms. So that's how is the word coined. But please note that the most common industries are battery industry, automobile, paint industry, toy industry. So these are industries which are related with plumbism. What is the basic pathophysiology? Point number 3. What is the basic pathophysiology in plumbism? With lead in your body, it will cause two important things. One, it interferes with the porphyrin metabolism. It interferes with the porphyrin metabolism. Because it interferes with the porphyrin metabolism, it actually inhibits the enzyme called as in the porphyrin metabolism. You must have heard it in biochemistry. In porphyrin metabolism, it inhibits the enzyme ferrochelatase. And it also inhibits the enzyme ALA dehydratase. So because it inhibits the ferrochelatase and there is inhibition of the ALA dehydratase, therefore in the urine, people will get coproporphyrins, which are the precursors before these enzymes, more coproporphyrin and more urinary ALA levels. So because it also inhibits porphyrin, it will cause anemia. Very important to understand that one feature is in lead toxicity is it causes anemia. The second mechanism which can happen with the lead toxicity, it binds to calcium and calmodulin to interfere with the neurological functions. That means the nerve functions, the conduction of the nerves. So technically there are two sets of problems now. One is about the neurological function. Second is about the anemia because it inhibits the porphyrin metabolism. So that is the reason we have lead toxicity as a problem. Based on this, if you understand this, you would understand what are the classical clinical feature. Just now we talked about clinical feature. What is the first feature you would see? Anemia. What is the most common type of the symptom that we will see? That is facial pallor. Facial pallor will be there. You can just remember the clinical features of lead toxicity. These are very simple to remember. You have A, B, C, D, and E. And F also, you can write it as F also. So B stands for Burtonian line. B also stands for basophilic stippling of RBCs. B also stands for the basophilic stippling of RBCs. C stands for abdominal colics. D stands for drops. How many types of drops? Many types of drops. We can have foot drops. The patient may have foot drops. Wrist drops could be there. E stands for encephalopathy. You remember problem with the neurological deficits? Encephalopathy. Or there could be memory deficits. And F, last F stands for the facial pallor. So you can remember this as the clinical features of lead toxicity, and very frequently they'll ask you about about the basophilic stippling of RBCs and the Burtonian line. What do you mean by the Burtonian line, beta? Burtonian line. What do you mean by the Burtonian line? So you can see that the Burtonian line is a bluish line. Can you see on the gums? I don't know, it's very small over here, but you can see actually a blue line on the gums. That is because of the lead deposition. That is what is called as the Burtonian's line. Next is coming to point number 5. As far as the diagnosis of lead or plumbism is concerned, please note that we can have something called as the screening tool. The screening tool for lead toxicity, we already had a discussion that lead would inhibit the furochelatase and the ALA dehydratase. So what is the screening tool we can have is the urinary coproporphyrin 3 levels, or we can check for the urinary ALA levels. Urinary ALA levels. Urinary ALA levels is a slightly more reliable parameter, but of course we can check both of them for screening for lead toxicity. Talking a little bit about the urinary ALA levels, it should be between 1 to 6 milligrams per 24 hours in normal people. It is 1 to 6 per 24 hours, whereas in lead toxicity, it could be as high as more than 70 milligrams per 24 hours. So when do we say that there is evidence of lead toxicity? When the urinary ALA levels are not like 7 or 8 or 10 or 20 or 15, they are more than 10 times of the normal levels. Then we think of lead toxicity. That is what is screening for lead toxicity. Next in line is, how do we diagnose confirmatory? What is the confirmatory test? Common sense, the confirmatory test has to be the blood lead levels. The blood lead levels, same issues. In me and you, normal people who are not working with the lead industry, it is usually less than 10 micrograms per deciliter. But people who are working with the occupational, those who have exposure to lead, there is some evidence of the occupational exposure to lead. The lead levels could be something range around 40 micrograms per deciliter. But that does not mean there is lead toxicity. There is a lead exposure, excess lead exposure, but it does not lead to toxicity. Usually at 40 micrograms, usually very subtle symptom or no symptoms are there. Only maybe some laboratory changes could happen, but in a person, there is no outside symptom, no wrist drop or foot drops or facial pallor, nothing of that sort. In blood lead levels, more than 70 micrograms per deciliter, there may be onset of symptoms, and at this level, the WHO says that the treatment should be initiated. The treatment should be initiated for lead levels in the blood more than 70 micrograms per deciliter. What is the treatment that we have for lead toxicity? We can have some of the lead chelating agents. Lead chelation is the only treatment that we have. That is Succimer, D-penicillamine. We can also use dimercaprol or calcium disodium EDTA. We can use all of these. So of course, calcium disodium EDTA is not used alone as a lone agent. It's always used along with some other chelating agents. But that's what is the treatment for lead toxicity. But all said and done, this is a preventive medicine. Therefore, what is the best way to avoid lead toxicity is to avoid the occupational exposure or to wear mask, because what is the most common route of lead toxicity? The most common route of lead toxicity is inhalation. Topic number 8 is, what do we mean by the decompression sickness? See, decompression sickness is seen in people who are deep sea divers. See, me and you, we are supposed to live on the land, right? You are not a fish. You don't go inside the sea. You are not a bird. You don't fly on the sky. You and me should be on the land. If you in case go to the bottom of the sea, let us say this person is swimming at the bottom of the sea. In case you are swimming at the bottom of the sea, don't you think there is a very high pressure of the water on top of you? If you would have remembered from your basic physics, do you remember from your 10th, 11th class in physics, we used to study something called as the Henry's law, that at very high pressure, the solubility of the gases will increase. So at very high pressure, the solubility of gases will increase. So if there is an increase in the solubility of gases, there is already nitrogen in the blood. There is already nitrogen in the blood. This person is swimming at the base of the sea. So now under high pressure, the nitrogen becomes soluble and it dissolves in water. Now, let us say that this person enjoyed having a look at all the fishes, oyster, all the sea creatures, and now he wants to come back because he's a land animal. So now this person wants to come back and he rapidly ascends. If there is a rapid ascent, please note that decompression sickness is not because of the descent, it is with rapid ascent. If there is a very rapid ascent of that person, now the nitrogen which was dissolved inside, it does not go back to the tissues, it forms bubbles. So the nitrogen solubility will decrease and forms bubbles. Now if there is bubble formation, now you are in a big problem now. Now this person will be in a big issue. The person is going to land up into a disease called as decompression sickness. So because of the nitrogen bubble formation, there is decompression sickness. This could be of two types. You can have type 1 of the decompression sickness or the type 2 of the decompression sickness. The type 1 is kind of a milder form. There is more bubble formation in the joints. So joint involvement is there. Plus there is more increase of the fluid from the vessels will go into the tissues. There is more edema. Whereas in the type 2 decompression sickness, there is a severe form where the bubbles could actually cause pulmonary edema. The bubbles could cause brain infarcts. The brain infarcts, the bubble can block the arteries in the brain, right? So there could be brain infarcts, there could be syringomyelia, there could be spinal cord infarcts, there could be brain infarcts, there could be pulmonary edema, there could be cardiac infarcts or cardiovascular effects. So type 2 decompression sickness, the type 2 decompression sickness is kind of a more severe decompression sickness. What is the only way to maybe treat it? The treatment of decompression sickness, treatment of decompression sickness is only to give them hyperbaric oxygen. Hyperbaric oxygen is the only way. However, the decompression sickness can always be prevented. The decompression sickness can always be prevented because under pressure the nitrogen is dissolved. You ascend very, very slowly. The ascent should be very, very slowly. There is no number because it depends on how deep the person went. So the more deep you go, the Henry laws apply more importantly on that. So please note that the ascent has to be very slow. That is what is decompression sickness. Next is this point number 9. What do you mean by the acute mountain sickness? I told you are not a fish, you are not a bird. So you don't go inside the water, you don't fly in the sky. If you fly in the sky more than 2,500 meters, if you fly more than 2,500 meters, you may land up into an acute mountain sickness if you do not acclimatize. If there is no acclimatization, the person may land up into acute mountain sickness. When does the person land up into acute mountain sickness? MCQ, it is more than 2,500 meters. What is this acute mountain sickness? Please note that if a person goes on the top of the mountain, there will be less oxygen, partial pressure. Please note, I'm not saying that there is less oxygen. Oxygen is same in this world. It is 21% everywhere in this world, but the partial pressure of oxygen, the air will be thinner on the top side. So the air being thinner, this causes a low partial pressure of the oxygen of the inhaled air. And because there is low partial pressure of the oxygen in the inhaled air, how can it go through the respiratory membrane? So this causes actually hypoxia. And this hypoxia will increase the ventilation drive and cause alkalosis. It will cause alkalosis, and this is what is acute mountain sickness. What is acute mountain sickness? When there is a rapid climbing up the mountain without knowing anything, and you climb up and you find there is no air. The partial pressure of oxygen in the air is very less. If the partial pressure of oxygen in the air is very less, how that air is going to transfuse through that respiratory membrane? If there is no gas exchange at the respiratory membrane, that is hypoxia, which causes a more ventilatory drive, which causes alkalosis. That is what is acute mountain sickness. Now, this acute mountain sickness can further be of two types. We can have something called as HAPE, or we can have the HACE. What is this HAPE? HAPE stands for high altitude pulmonary edema. HAPE stands for high altitude pulmonary edema, or we can have HACE, that is high altitude cerebral edema. So what is all this? Very simple to understand. HAPE is like pulmonary, involving the pulmonary circulation. As the person is going to ascend on the mountain, the person is going to find there is less amount of partial pressure of the oxygen. So if the less partial pressure of the oxygen, this causes immediately, because there is less partial pressure of the oxygen, this causes a vasoconstriction. It causes a vasoconstriction in the pulmonary circulation. In the pulmonary circulation, there is vasoconstriction, and because there is vasoconstriction, this further will lead to hypoxia. This further will lead to hypoxia in the patient, and hypoxia will land up into alkalosis. Hypoxia will land up into alkalosis. Now, because there is hypoxia in the body, the brain needs oxygen. The brain is going to have vasodilation in the brain. So please note that if there is vasoconstriction in the lungs, that is going to cause a pulmonary edema in the lungs, and hypoxia and pulmonary edema, that is what is HAPE. In case, because there is hypoxia, now this hypoxia is going to cause the vasodilation of the brain, and there might be a cerebral edema, that is HACE. So technically speaking, HAPE will cause HACE and HACE will cause more HAPE. So they just are related. This is what is acute mountain sickness. The only way to treat is to give 100% oxygen and to have a slow ascent. To have a slow ascent, the ascent should not be more than 200 to 300 meters per minute. Sorry, not second. It is per minute. So that is what is the acute mountain sickness. Point number 10 is what is the prevention of occupational diseases. So a lot of occupational diseases we have learned. So how do we prevent these different occupational diseases? Beta, for the prevention of occupational diseases, we can classify the prevention modality into three broad categories. We can have something called as the medical measures, where we can see that the patient, the person to whom we are employing, that person should have a pre-placement examination medical checkup. We can also do periodic medical checkups, notification of diseases, health records, analysis, health education, so on. These are the medical measures. The engineering measures is that the structure, whatever the industry you're working in or the person might be working in, the structure should be robust. There should be good housekeeping. This is called as the occupational sanitation. What do you mean by occupational sanitation? Occupational sanitation is that whatever is the workplace, the person should be having a good water supply, a good air quality, and a decent amount of space to work. So this is what is occupational sanitation. Along with that, there should be good ventilation, dust control should be there, substitution for any harmful chemicals, mechanization of the machine should be, everything should be there. Like for example, if a person is mixing some chemicals with the hand, instead of mixing with the hand, give them an electronic mixer, right? We have so many things. So we can use a lot of machines and protective equipments for saving the ears, for the inhalation and everything. Then there is also, we can use some legal measures as prevention of occupational hazards that we are going to study in a separate module, that is the Factories Act 1948 and the Employee State Insurance ESI Act 1948. So that was about your medical measures, engineering measures, and legislations. What do you mean by sickness and absenteeism? Please note that sickness absenteeism, it is a sensitive indicator about the occupational occupational health of employees. It is given by a very simple formula. It is the total number of worker days absent divided by the total worker days multiplied by 100. That is what is sickness absenteeism. So the higher the sickness absenteeism, that means that the low is the occupational health of the employees. Very simple to understand. If there are 10 workers and they are absent for 10 days, so how many worker days they are absent? That is 10 into 10, that is 100. So you just calculate the total number of work days absent divided by the total work days which are present and multiplied by 100. That is a very sensitive indicator for the health of the occupational people, of the workers in your occupation. Next is, a lot of times questions are being asked about the pre-placement examination. Beta, this is again a 3 by 5 star MCQ topic. When a worker is being employed in any hazardous industry, before employment, we should always have a pre-placement examination. For example, if we are dealing with some lead-based industries, paint industry, toy industry, some pipe making industry, or automobile or the battery industry, you should check the person for anemia levels, hypertension, nephritis, and about the peptic ulcers. In case we are talking about the dye industry, we have had a lot of talk on this just a few minutes back about the textile industry or the dye industry. We should check the patient for skin or bladder or the kidney diseases and any pre-cancerous lesion. That is important because dye industry is associated with a lot of cancers, specifically talking about the bladder cancer. Then you have solvents. Very importantly, we talked about the vinyl chloride and the liver disease or liver cancers, liver and kidney disease, dermatitis, alcoholism. Talking about silica, that is pulmonary tuberculosis, and all the ionizing radiations are responsible for blood disorders. So therefore, these things should be always checked whenever we are posting a person in these hazardous occupation. And food handlers, common sense, that if, let us say, a person is there to work in a food handling industry, we should common sense check for them for hepatitis, typhoid, contagious disease, or any other communicable diseases. So now this was about that the worker was trying to enter into some occupation, or we have hired a new worker. That is what is a pre-placement examination. Talking next further is that in case you already have a worker, we should check them for medical checkups. That is called as a periodic medical examination. Periodic medical examination. Please note that the periodic medical examination could be done annually. It is usually done for all occupations. But for hazardous occupations, we might even do monthly, or we might even do daily, or we might even do event-based examination. What is all this? So annually it is done for more or less all the occupations. We get an annual medical checkup for all the workers, usually in all the occupations. Talking about which occupations require monthly checking, that is usually for lead industries, for the dye industries, for the radium or the ionizing radiation industry, and also for the heavy chemicals. Please note that daily checking should be done for industries which use this dichromate. So dichromate is one chemical which is used in a lot of leather making industry, photography industry. Dichromate, wherever it is used, it is checked on daily basis. The person should be checked on daily basis. And event type is very simple to understand, that before the event, every time we should check. This is done as a pre-flight medical checkup. Pre-flight medical checkups, the PFMC, that is the pre-flight medical checkups, that is done to all the crew members and the pilot, because a lot of people are their responsibility. So the pre-flight medical checkup is an event-based medical checkup where the people or the organization will actually be checking about the 0 levels of alcohol. And then daily is for dichromate, monthly is for these industries, lead, dye, radium, and all these things. Point number 11 has been very recently, it is a new introduction into your CBME curriculum, into the competency-based medical education system, that is prevention of occupational diseases for health professionals. I should not be talking about this because we all are doctors and we have had occupational health exposures. But I should be talking about this because we all are doctors and at least we should know about it. So, what are the different diseases or what are the occupational hazards that we may be exposed to? Could be like many of them. So, some of them I could list over here, that we may be exposed to occupational infections. Which is the most common occupational infections? It is the hepatitis B, hepatitis C. It is also the HIV viruses. So we can be exposed to a lot of infections. If I just show you the WHO profile over here, they have told that the needle stick injuries contribute to 40%, 39, 37, 4.4% of the hepatitis C and hepatitis B. Can you imagine 40% of hepatitis B and C is because of the needle stick injury, and also 5% is because of for the HIV. So needle stick injury is one of the important problems that at least the doctors and the nurses and the healthcare professionals will face for occupational infections. Unsafe patient handling, that sometimes we have to pick up the patient has a lot of bed sores, and many times the nurses will have to pick up the patient, or even the interns or the doctors, we have to help the patient for making them stand or sit, and because of that many times we get musculoskeletal diseases, musculoskeletal disorders. So exposure to hazardous chemical is definitely there. We all are working day in, day out with all the detergents and all the solvents, and all the alcohol-based hand rubs are there. So with the hand rubs, I think we all know that how it damages our spectacles also. A lot of times, like the color would go off of spectacles, the hands become very dry because of using gloves the whole day. So these are exposure to hazardous chemicals. Also, if we talk about the hazardous chemical, there could also be some problem. One is with the skin or the dermatitis. There could also be related problem that we are inhaling so many solvents over there. So if I show you the WHO report again, can you see that the cleaning agents and disinfectants have been associated with the 70% increase in the asthma level in nurses. So that is again an occupational health exposure, because the nurses or the healthcare professionals will be inhaling all these solvents day in, day out. Then is exposure to radiations, which of course we understand in radiotherapy or in the radiology department, we are always exposed to ionizing radiations, UV radiations and so on. So these are responsible for the skin cancers or the blood cancers, if you remember. Then we definitely have occupational stress and burnout because of the quantum of the work that are being given to the doctors and to the healthcare professionals. But all said and done, this is what is the noble profession. We are also exposed to violence and harassment. I think every person, every doctor, every nurse in the country would have had at least one violence or harassment exposure. If I just show you the WHO report, it says that in your lifetime, 62% of the health workers have any time experienced violence in during their curriculum or during their workstations. So verbal abuse is the most common type of non-physical violence, which is there in 60%, which is 2/3 types of violence is verbal abuse, followed by threats and sexual harassments. Then we are also prone to occupational injuries, specifically talking when we are talking in a government-based hospital where we all have been working in a government hospital, right? So in the government hospital, the emergency room will be this much only. In that, there will be two patients, two doctors doing suturing left and right, and then there is a patient on which a person is doing CPR, so you don't have space to walk around. So you bang your head, you put your knee on the bed, your knee gets swollen. So many occupational injuries happen because of less space, or the wire, you might trip on the heater wire or anything. Then is environmental health hazards, because we are there in a government setup. Usually, many of us would be there in the government setup. And in a government setup, usually on an average, 500 to 1,000, depend on what level we are working. 500 patients, 1,000 patients are coming to our area, and everybody is touching my table. Everybody is sitting and talking to me like this, and we are drinking the same water which other patients might be drinking, or we are using the washroom facilities. So that is a big type of occupational environmental hazard. So these are some of the diseases which we as doctors are exposed to, or even the nurses or all types of healthcare professionals would be exposed to. Next is, before we close off, I would just like to appraise you. I would just like you to know that there are some occupational health institutes located in India at different levels, which is the Apex Institute. The Apex Institute is the National Institute of Occupational Health, NIOH, which is located in Ahmedabad, which is in Gujarat. We also have the Central Labour Institute in Mumbai. Regional Labour Institutes are at different places. Central Mining and Research Station, that is CSIR, which is in Dhanbad in Bihar. Then we have the Industrial Toxicology Research Center, which is in Uttar Pradesh, Lucknow, and the National Institute in Environmental Engineering Research Institute, that is the NEERI, which is in Nagpur, Maharashtra. So these are some of the occupational health institutes which are of prime importance. The Apex Institute is National Institute of Health. So that was regarding most of the MCQs which you need to know from the occupational health from community medicine. Thank you so much.
Hi guys, please subscribe my channels.